Hello, everybody, and welcome back to today's episode of To Me Time. I am your host, Megan, and on today's episode, I'm going to continue the conversation about the transition into practice for new grad nurse practitioners or new providers out there. And today's topic is going to be about trying to answer the question of when does it get better? When does my day get better as a provider? When do I start feeling more comfortable? And when does all this imposter syndrome go away or start to ease up? We all know that. I know I ask that question quite often to myself. I ask that question to my mentors, and it is definitely a pretty commonly asked question. And so I'm going to kind of deload some of that today and kind of talk about some of the ins and outs of that question and why we always ask that for new providers and why we're constantly asking about that. So when we ask ourselves, when is it going to get better? When am I going to get better at doing my job? When is it going to get smoother? That's because the beginning part of your career as a provider can be very difficult. And oftentimes it's just because you're new to practice, you're new to your patients are new to you. And the whole process of transitioning into that provider role is just it's a change, it's a challenge. And of course, it's going to take some time to get used to. And of course, as a provider, it's very different than your previous role for nurse practitioners as an RN or in whatever other role you had. And then it's also very different when you're the one managing and making the decisions versus having your preceptor with you that you can bounce ideas off of quite frequently or for every patient, and having that reassurance that, yeah, this is the best plan of care. So I think that's why the first month and 2 and 3 months are so scary and just so hard and so different. It's because it's a total new role as a provider. I do have some good news because I do think that there are some things that will get easier more quickly right away, and some things that you likely will be working on for most of your adult or most of your career as a provider, and constantly perfecting and working on some of those skill sets and some of those skills. Now, I am speaking from a primary care perspective. So I am speaking as a primary care provider. I have been in practice about 3 years, so keep that in mind as well. I also switched from a primary care setting into a specialty setting as a women's health nurse practitioner, and then transitioned back into primary care because I really missed primary care. So take that into consideration as well when I talk about this, because I have made some transitions. And so I haven't necessarily stayed in one spot for 3 years plus. So my trajectory of how I'm feeling would probably be maybe a little bit different than somebody else's, but it's kind of neat to see the differences between primary care and then also a specialty role, and how there are different timelines with both of those and when you start feeling more comfortable. So for some of the, specifically from a primary care perspective, one of the first things that you're going to start to notice that gets a little bit easier and pretty quickly is going to be the big knowledge gap. So, what I mean by that is, as primary care providers, the knowledge gap is so large. There's so much information that we do not know. There's always going to be something we do not know that we are not an expert at. This is why it's primary care. There's going to be patients we need to connect with specialists for certain reasons. There's going to be times where curbside consulting with specialists or with our mentors or even with our other colleagues about certain information. So knowing that you're not going to know everything, you just got to get comfortable with that, number one. Number two, I also think that some of the nitty gritty, that knowledge gap, you're going to constantly be chipping away at every day you're at work. Your knowledge set is going to grow and grow and grow. So instead of going in for your first week to 2 weeks to month on the job to first 2 months, maybe 3 months, where you're constantly looking up information for almost every patient, that's going to get better. Instead of looking up dosing for every single antibiotic you're prescribing, looking at medication interactions, looking up renal dosing, looking up the length that you want to prescribe these medications for, if it's something more urgently like bacterial infections, you're going to know that information because it's going to be super repetitive. So even if it's a new environment to you, you're coming from a different specialty, coming into primary care, and you're refreshing your knowledge base on these medical conditions and treatment of them, it's going to become more repetitive because you're going to start to see the same thing over and over again. So that's where the comfortability comes from, is doing something over and over again, and also seeing something multiple times. So you're not always having to go and look it up. Even if you do choose to look it up every time, it's going to be more of a confirmatory, quick lookup versus really like diving into the details about how long to treat. What do you do when treatment of failure happens? What do you do if, they're allergic to X, Y, and Z antibiotics class? What do you switch with? So those are some things that are just naturally going to get faster. Also, you're seeing similar patient populations. So if you work in urgent care setting or in a specialty setting, you might be doing similar procedural skills or the same thing over and over again throughout your day. And so, of course, you're going to feel more comfortable doing those because you're doing them more frequently. Versus primary care, that's not always true. Yes, you're seeing things like chronic medical management and conditions that are all the same, but every patient scenario is a little bit different. Their group of illnesses that they have is different from patient to patient. And somebody that has diabetes without kidney disease is very different than somebody that just has diabetes with kidney disease. So these are like nuances of something that you might see all the time, but their management is going to be very different now versus somebody that comes in with a UTI or an ear infection or a respiratory illness or asthma exacerbation. So these are all things that are more routine per se, that you might have more exposure to, that you're going to get more and more comfortable with if you aren't already comfortable with them from your time as a student. So those visits will start to get easier. They'll also become faster because you're going to be faster. You already have a plan. You know what your go to plan is. You know what your general treatment options are. And you know when your general treatment option probably isn't going to be effective for that patient based on their presenting symptoms. You're also going to understand when you need to bring them back to see them again next if needed. So, those are some things that are going to get more comfortable more quickly. Also, you're going to get faster with your EHR. You're going to get your electronic health record. You're going to feel more confident in 2-3 months. You're going to be super fast now. It's becoming more muscle memory. Ordering things and then getting them completed and closing those charts are going to become faster. So the beginning phases are just slow. They're slow because you're taking extra time looking up knowledge deficits, you're looking up information, you're double checking your work, you may be consulting with a collaborating provider or your mentor to make sure your plan of care is appropriate. You might be second guessing yourself. So you're going to be taking more time naturally to see that patient and to close that note. That will get better. And that just comes with pure time and the amount of time that you're seeing these patients, and also repetition and seeing the same patients in similar clinical scenarios over and over again. The other thing is your team management's going to get better. That means you're going to get better at delegating tasks. Your team is going to build a rapport and a relationship with you, and your medical assistant or your nurse or whoever is working up your patients for you in collaboration with you is going to understand what you need and what you want for each patient before you see them. So for example, if they're coming in for lower abdominal pain or some lower back pain or UTI symptoms, they know that they already need to have a urine. If it's a if it's someone that we need to rule out pregnancy for, we're going to rule out pregnancy before you even walk in the room. So you're going to have that all lined up and teed up. So by the time you see the patient, you can see the patient and there's no back and forth of like, oh, they need a urine, they need a pregnancy test, they need this and that. And then I can go see the patient. If the patient is coming in for 6 symptoms of acute respiratory illness or fevers, chills, sore throat, body aches, they're already getting a flu swab, a COVID swab, and a strep throat rapid. And so you have all that information before you walk in. So there's no lag time between going in, asking for it, and coming back out. So that will naturally grow with your team too. So the first couple of months are just rough because you're ironing all that out, not to mention having to understand what your community resources are, to understand who your specialists are, to understand how to get patients quickly in to see certain specialists. You're establishing that rapport as well. So that can take some time. Now, I also want to highlight the fact that specifically in primary care, another reason why the transition is so rough and so hard and it doesn't get better probably until about a year or a year and a half in is because you're not seeing the same patient every single day over and over again, or even the same thing. So sometimes it might be a whole year until you see that patient again, or maybe a whole 6 months until you see that patient again, sometimes 3 months or sooner, depending on how critical their condition is. But it's that time between when you see the patient the first time into seeing him the second time, and that amount of time it takes in between is why it kind of makes it difficult. Because when you meet a brand new patient, you might not have enough time to gather their medical history, to really understand their medical knowledge fully, to close their care gaps, to screen them for cancers that they need to be screened for, and also care about and also address their concerns that they're coming in for that day. So that leaves you with little time to kind of do everything. So that's another challenge because you just don't have time. And the current healthcare model doesn't allow you to really to really give doesn't give you an opportunity to do everything you want to do at that one visit without running behind on scheduled time, especially if your clinic is not one that kind of is flexible with adding more time for brand new patients or follow-ups or really complex patients. So that can also cause a lot of stress for new providers and providers that have been in practice for a long time, because it's hard when you see new patients and people you do not know. It is harder to go through all the information. You feel obligated to go through all their previous history if you have it, so you fully understand and that you're well aware of their medical history at that time. So with that being said, knowing that it's going to be hard, it is helpful for you as a provider to set expectations for your patients and also have your medical team do this as well, and your support staff do this as well, so that your team is really focused on trying to give the best care in the time allotted. So setting expectations with the patient. Hey, this is your meet and greet, established care appointment with your provider. This is a 15 or 20-minute visit. Are there certain healthcare concerns that you need to address today? If they come up with a long list, your medical assistant should already be kind of gearing them towards, hey, are there one or two things that are top on your list that you definitely wanted to address with her today? Now, as a provider, you, of course, have your own list. You have your own needs that you need for the patient. You have your screening and recommendations for the patient. You have your own agenda that, of course, you want to talk about as well. But knowing that most of those new patients are coming in with a medical complaint or a medical concern, you need to realize that as well. I have found that, especially with new patients, sometimes by just saying, addressing their concern that they have that day, and whatever concern, maybe they have two concerns that we can really have time to talk about. And then at the end of the visit, I can say, hey, you know what? We talked about a lot, but obviously we did not get to everything. I still really want to get to know you. I want to address all your other concerns that you have. Is there a way that you can, let's schedule an appointment for 2 weeks from now or a month from now, and we can continue the conversation and get to some of the other medical concerns that you have. And then also, if you have time, now's a great opportunity to say, I also noticed that you missed your mammogram this year. I would like to put an order in for you. Is that okay? This is where you can go and get that order completed. So by the time you see them again, you did end up accomplishing something that you thought was important for their own health and wellness. Also, more patients seem to be very receptive towards that. So if you took the time to really talk with them, listen to them, hear them, feel like they're being seen and heard, they're going to be a lot more receptive to you at the end of the visit, trying to close in on some of their care gaps that they have. So that can be a helpful tool that providers can use, new and old. And it's easier said than done to limit the length of the visit, but that's sometimes what you have to do to get used until you're more comfortable being on time, and until you're seeing patients over and over again. You might need to utilize those tools and bring them back more frequently. You might just know and set up that expectation. Hey, it might take I see you have a complex medical history. I want to make sure we have the opportunity to discuss all your healthcare concerns. It might take us a few visits to really get to know one another. And most of the time, patients are open and receptive to that. So on the other hand, something that can be hard to learn how to do, that probably takes I would say it can take a couple of months to get even comfortable doing this well, is to cut off the visit. So, how and when to know to cut off the visit. So, how do you say, hey, unfortunately, our time here has come to an end today. We are out of time. And then you transition into your exit speech about wanting to see them again, to address all their other healthcare concerns that you also want to get down to discuss. So you're going to bring them back for another visit. So getting your elevator speech to exit is also really important, and starting to perfect that, especially early on in your career, so that you have a way to get out of a visit that you already know that, hey, we've been in, that you've extended your time too long. So that's something else that you can utilize in your toolbox while you're working in this transitional time frame. So yeah, those are some things that I think take a while to get used to. Some other things that might take take a while to get used to is just the sheer amount of. I personally think that like the holy grail, the end of the road for when am I going to feel comfortable? When am I going to feel super confident? Comes down to when you've perfected your time management, when you've seen patients on time, or as close to on time as possible. You've completed their charting, you've closed their notes, and you actually get to use your admin time for things like reviewing labs, reviewing images, and care coordination as much as possible, and leaving on time when you can. So that is like the holy grail of medicine. And I don't know if it's possible. I hope it's possible. I haven't reached that point yet. I hope one day I can. It's constantly an improvement. But I think that's for me what my goal is one day to work towards. And like I said, I'm not sure if it's possible, but hopefully it can be. Now, some of the other things that I think are tough during the transitional phase, but that will get easier and that you will get better at, are those sick patients that come in that you're debating on if you're going to send them to the emergency room or not. Now, some of you might say, well, Megan, well, why? That seems like super easy. You realize like, hey, no, this is a more emergent issue. You need to go to the emergency room for workup versus working this up outpatient. Sometimes those waters can get really murky. One, maybe at first you're wanting to manage something outpatient, and but something's not sitting right, and you feel like they really need to go to the emergency room, but maybe the patient doesn't want to go to the emergency room and won't go. So then you have to become comfortable with managing or helping managing some of these patients outpatient, and giving the advice of like, hey, I really think you need to be seen in the emergency room, and this is why, it's important. Make sure you're documenting that as well. But also a lot of, where I work right now, there's a lot of patients that don't want to go to the emergency room for various reasons. So I think that's also been kind of a hard struggle when I was a new provider, is getting comfortable with those patients, knowing that they're probably not going to go in, or those patients that are really sick that don't follow up as often. You just have to get comfortable with the fact that they might not show up. They might not come in for their follow-up visit, despite them being very sick. And despite you explaining that can be really hard to just learn, to understand that and to let that go sometimes. So that's hard to grow and to learn and to understand, but that will get faster, and you'll just part of also seeing these really medically complex patients, your exam, what's important, and narrowing down what your goals are each visit will become faster and more simplistic for you as you experience it more and more. So that's just a little bit of nuances of like what I think of when I think of, will it get easier? Does it get easier? I think it does. I think it goes in waves. I think there are certain times in your career that you're going to feel like things are going well. And when they're going well, make sure you recognize yourself for them going well and understanding why it's going well for you. So when you have maybe a mentee that's reaching out to you saying that when does it get better? How does it get better? Be honest with them, but also, discuss that it's a learning process, and a process that probably takes many, many years, if not a decade, to fully perfect, and just, come to meet them where they are, and, really highlight areas where they have improved on and where they are seeing themselves get better and improving. So Anyways, thanks for so much for tuning in to today's episode. Again, you can find all the episodes on Spotify at To Me Time. You can also find my channel on YouTube and Instagram at To Me Time. You can also send me an email at to me, the number 2 time at gmail.com. Thanks so much for listening in, and please don't forget to like and comment. See you next time on To Me Time.